Good afternoon,
Good
sir.
afternoon, sir.
के छ तिमीहरुको हालखबर?
Good afternoon, sir.
हँ?
ठिक छ सर, चलिरहेछ जिन्दगी।
चलिरहेछ, जिन्दगी चलिरहेछ। अनि कतिको मिस भइरहेछ त गोलको?
भइरहेछ सर।
Last day भइरहेछ सर, last day.
अरू दिनमा शुक्रबारको मिसै हुन्छ होला हैन?
सर कहिले खुल्छ यो लकडाउन? कहिले खुल्छ यो लकडाउन?
लकडाउन अस्तिसम्म खुल्ला।
दशैँसम्म?
दसैँ मनाएर आउने सर हो त?
एकैचोटि दसैँ मनाउने भयो हैन? अझ त्यसपछि मङ्सिरसम्म मिल्यो भने मङ्सिरमा झेमिनी पार्ने अनि दुई जना आउने हैन?
हुन्छ सर।
अनि कस्तो छ पढाइ? अलिअलि पढाइ
खुले पनि सर कलेज खुल्दैन होला नि? लकडाउन खुले पनि खुकुलो भए पनि अनि कलेज चाहिँ कस्तो खुल्ने चान्सेस कतिको छ?
हैन त्यही त लकडाउन खुले पनि अलि तुरुन्तै कलेज त खुल्दैन। कलेज खुल्दैन।
ठीक छ।
हैन लकडाउन खुकुलो भएर 1.5 महिनासम्म नयाँ केस आएन भने बल्ल खुल्ने हैन?
सर 70 दिन भइसक्यो लकडाउन भएको, झन् केस बढै छ
हैन? नेपालमा झन् रेड जोनमा छ अनि कहाँबाट खुल्ने हो नि त? कतिको गर्मी छ तिमीहरुकोतिर?
शीतलै छ हाम्रोतिर त।
सबै आइपुग्यो? कतिजना आइपुग्यो यार?
धेरै बाँकी छ सर अझै।
आउन बाँकी छ?
155, 50, 60 जति हुनुपर्ने।
कतिजना
कम्बाइन्ड
कतिजना कसरी थाहा पाउने? के हो यार तिमीहरु यार घरमा बसे पनि यार कम्प्युटर बनाइदिए गाह्रो क्लासमा पनि आउँदैन थियो टाइममा।
सर यो आजको टाइमिङ अलिकति गलत भएर हो।
यो त प्रिन्सिपल अफिसको काम हो टाइमिङ गलत यार। मलाई त पहिला बिहान भनेको थियो, मर्निङमा भनेको थियो, पछि फेरि के छ रे कतिवटा क्लास के रे भनेर चेन्ज गरे। प्रिन्सिपल अफिसको कमजोरी हो। फाइभ मिनटमा म सुरु गर्छु यार, 3-5 भइसक्यो। कतिजना आएछ? म 96।
स्टार्ट गरे त हुन्थ्यो होला सर, बिस्तारै आउँछन् अब।
2-3 मिनेट पक्का।
ब्रो यार सबजना आएपछि बरु स्टार्ट गरे भइहाल्छ नि।
नि अरु के छ त खै तिमीहरुको त यहाँ त फेस के पनि देखिन त। फेसलुका हो?
यस नो सर।
रिकेश छैन। कतिको सय काट्यो? Okay, I think we should start now. Hey, let's begin our class. 3, 5, 3, 10 भइसक्यो हैन आउने आउँछन् आउने आउँदैन Okay, so shall we begin? Class ready?
Yes, sir.
Yes, sir.
I think we should begin. It's getting late. Okay, good afternoon to you all. So today we are going to discuss about another hematological disorder, which is one of the rarest disorder in hematology. It is known as the disease of the old people, MYELODISPLASTIC syndromes. It is a type of hematological disorder which usually occurs in old age group. So let's begin with our topic. Okay, let's begin with the definition. What is myelodysplastic syndrome? Thank you. It is a group of clonal hematological disorders. It is a heterogeneous group of clonal disorders which manifest clinically by peripheral cytopenias. Cytopenias means that there should be at least 2 lines of decreased cells. That means either anemia or thrombocytopenia or anemia, thrombocytopenia, leukopenia. There are at least 2 भन्दा बढी हुनु पर्यो and pathologically by hypercellular bone marrow with dysplastic cells in one or more line. That means you have peripherally it manifests as cytopenias. It may manifest as anemia, thrombocytopenia or leukopenia, and pathologically it manifests as hypercellular bone marrow. So it's a sort of contradiction. You have a hypercellular bone marrow, but still you are having cytopenias in peripheral blood. But the thing is that despite of having hypercellular bone marrow, the cells that is produced from the bone marrow is dysplastic. These are not normal cells. And these should be shown in at least 1 or more line. That means either thrombocytes, RBC erythrocytes or leukocytes. मध्ये एउटा भन्दा बढीमा देखिनु पर्यो this plastic cells. So though there is a hypercellular marrow dysplasia lead to immaturity, cell death and cytopenia. The thing is that usually what happens that when you have a hypercellular bone marrow, there should be increased in number of peripheral cells. That is a linear relation. But despite of having hypercellular bone marrow, but in peripheral blood you have a cytopenia. It happens because of dysplasia. Dysplasia means there is no normal cell. And because of that abnormal cells, what happens that these abnormal cells are destroyed. And that leads to cytopenia, peripheral cytopenia. And why we are so much, worried about MDS diagnosis or the treatment, it has higher tendency to progress to AML. It may lead to the AML. So it is sometimes known as pre-leukemic stage. It is sometimes called as pre-leukemic stage. And MDS pre-leukemic stage managed. Diagnosis is very important because once it turns into acute leukemia AML, it is very difficult to treat. AML ma convert basically treatment becomes difficult and prognosis will become bad. Right? Okay, let's talk about the epidemiology of disease. So it's a common disease in elderly population. Remember that it is known as the disease of the old age. That means usually its prevalence is more in up to 60, 70 years. And so most of the incidence and prevalence are seen in above 60 years. And mean age of diagnosis is 70 years. And it's the mean age of diagnosis. Most of these patients are diagnosed around 70 years. And so prevalence is almost 30 per lakh populations in population of 70 years old, right? The onomatic population of prevalence is 30 lakh. So it's not a very common disease, it's something like a rare disease. But as compared to young age group, it is common in old age group. In Asia, mean age of diagnosis is 50 years. I don't know why it is less in Asian populations. As compared to European and American populations, mean age of diagnosis in Asian population is 50 years, almost 20 years to difference. Maybe because the Asian people have very short half-life. I don't know what is the reason. But but in Asian population, it is diagnosed much earlier than that of old age populations. European American population. Okay, so it's more common in male. It's a disease of a male and rare in children and young adults. So it is very rare in case of young children and adults. Right? So what we learn from epidemiology is the old age, which is very common, 70 years above populations, and the thing is that it is rarely seen in children and in adults. Okay, what are the risk factors for MDS? MDS risk factors. So basically, the risk factors are similar to that of most of the leukemias. Leukemia risk factors is almost the same. That means all those exposure to various kind of chemicals, radiations, and something like that. And so it is something like a pre-leukemic state. Pre-leukemic state, physiology. It's something similar to or other kind of leukemia. And so risk factors are exposure to benzenes, chloramphenicals, and a chloramphenicol is drug which was quite commonly used for treatment of injury fever as well almost 30 years back. Radiation, various kind of radiations, which now radiation in radiology department, radiation in cancer treatments and chemotherapy, various kind of chemotherapy drugs like alkylating agent like busulfan, nitrogen. These are the drugs which are themselves used for treatment of various kind of cancers and leukemia. The thing is that there should be in calculated dosage. Full exposures, they themselves can cause MDS and various kind of petroleum products and petroleum products relation and pre-existing myeloproliferative. Those patients who already have myeloproliferative disorders like polycythemia, CML, or having these kind of disorders, they have a high risk of developing MDS. So these are the risk factors, and while we are thinking about MDS, we should think about these risk factors. And patient has any exposure to these factors or not. Okay, let's move to pathogenesis. How it happens. I'm not going to talk in detail about the pathogenesis. I will give you the overview totally because most of the pathogenesis of the disease in India is in genetic level. Genetic level to mutations are via so it's not that important for you guys and it's that important to these genetic things. But the things you should know that, and there is, pathogenesis of MDS is mainly due to genetic mutations, and that mutation will lead to cytopenias. There is kind of genetic mutation that leads to dysplastic cells formation, and this dysplastic cell formation eventually lead to what? Cytopenias and hypercellular, and that is the main. So cytopenias, despite of hypercellular marrow, is the basic thing in the MDS. And usually what happens that most of the time, if we have hypercellular marrow, we have increased number of cytosis in the peripheral blood. And some kind of leukemia, you have increased number of WBC. 4 lakh, 11,000 but in case of MDS, despite of having hypercellular marrow, if you do a bone marrow examination, marrow is hypercellular, but in periphery it is, WBC, RBCs and from platelets are decreased in spite of this. So what it shows that despite of increased number of cells production in the bone marrow, most of these cells are destroyed before reaching the what? Peripheral blood. And peripheral blood ma distributions. It may be the destruction may happen in the bone marrow itself or in a different kind of organs, like spleen normal and sequestration bar, they may have a destruction. So malignant stem cell shows increased proliferations, but accelerated apoptosis lead to ineffective maturation and cell death and cytopenia. So what happens that there is genetic defect in the stem cell itself, and so what happens that when there is proliferation of stem cells and proliferation of stem cells, and there will be apoptosis, increased apoptosis, and because of this genetic disturbances and the stem cells, what happens? There is an abnormal cell formation. These abnormal cells are dysplastic in nature, and that means abnormal cells. In this dysplastic cells, despite of having increased number of dysplastic cells, they cannot survive the normal life span. They cannot survive the normal life span like other normal cells. And so what happens that most of these cells will die before reaching the peripheral blood. Accelerated apoptosis. Apoptosis, you know what is apoptosis? Acha?
Programmed cell death.
Program cell death.
Cell death.
So what happens that in normal cells you have a life cycle, and for RBC you have 120 days to life cycle also. But in case of dysplastic RBC, what happens then? They won't survive that long. They will die in 20 days, 10 days, and 5 days. It happens like that. And so despite the formation of cells, they will die earlier, and that leads to cytopenia. Accelerated apoptosis is due to various factors, cytokines, endothelial growth factor, T-cell mediated immune response, cytogenetic abnormality. There are so many things interacting with each other. And so at the genetic level and at the various cytokines productions and whatever it is. So what happens that despite of this, all these things, you have hypercellular marrows and there is cell productions, but these cells are not normal cells, these are dysplastic cells, and this because of this dysplasia, these cells will not survive a normal life cycle. They will die earlier, and that leads to cytopenias. Yeah. Any questions till now? Okay. Basically, MDS is divided into groups, primary and secondary. Primary usually means due to genetic mutations and various kind of genetic causes. And genetic causes MDS, which is known as primary MDS. And that constitutes almost 80 to 90% of the MDS. So majority group of MDS is primary, which happens due to genetic causes. Secondary MDS usually means those MDS which are due to exposure to various kind of chemotherapeutic drugs, secondary to myeloproliferative disease. These are known as secondary MDS, which constitutes around 20%. And 10 to 20%. So the thing is that measure of the MDS is primary, and so our treatment is mainly focused on primary MDS. Okay, now let's move to the classification. WHO has classified the MDS in 6 groups. Why this classification is important? In WHO classification, MDS it's much easier for us to study, but still they have classified, because this classification is necessary, because of this classification, what happens, this will define the prognosis of the disease. And different classes of drug has different prognosis. Some have better prognosis, some have worse prognosis, and treatment may be different, slightly different in different class of MDS. Treatment effective, that's why it is classified. So usually now newer classification is MDS with single lineage dysplasia, means only one line of cells is dysplastic. That means either RBC cells are dysplastic, either platelets line of cells are dysplastic, or either WBC line of cells are dysplastic. And MDS with multilineage dysplasia, in SMASA you have at least 2 lines of cells are dysplastic. And MDS with ring sideroblast. In MDS with ring sideroblast, what happens that we will get sideroblastic cells. There are special kind of cells which are seen, and like in sideroblastic anemia. In MDS with excess blast, this is the case where you will see blast cells and excess blast, normal body blast. Blast cells are also seen in amounts. Blast cells के मा देखिन्छ अरु. When you see the blast cells in leukemia, blastitis, you have a excessive blast cells, and acute leukemia मा के हुन्छ, there will be increase in blast cells, and MDS unclassified means which does not fit in any of this group, or which have a mixed character of different other groups, and MDS को different other group मा पनि सबै group केही न केही character मिल्यो भने that is MDS unclassified, अर्थात which doesn't have any character related to this classification. And so this is basically classification. यसको अब सब classification पनि छ यसभित्र हैन. It's not that necessary for you guys, but why it is pathologically important is to tailor the treatment to certain to tell the prognosis, and prognosis explain गर्नलाई treatment tailor गर्न, अर्थात कुन treatment is more effective भनेर हेर्न. Okay, let's move to the clinical manifestations. And what is the clinical manifestations of the disease? How they present? And the thing is that, as we have said, that and most common manifestation of the disease is always cytopenias. And the suspicion of MDS is higher when patient present with cytopenia. But there are so many other conditions where you can have cytopenias, and cytopenias the There are hundreds of conditions where you can see schizophrenia, but there should be some epidemiological factor which defines cytopenias, and we have to rule out other causes of cytopenia as well. Now, cytopenia, you can't suspect MDS, and because MDS is one of the rarest disease, very common. There are so many other causes of cytopenias which are more common than this. Okay? So 50% patients are asymptomatic. Remember that almost half of these MDS patients are asymptomatic and discovered incidentally. And they are discovered incidentally. That means when you are patient do not have symptoms, but you are doing blood examination of this patient for some other reason. And if they have done insurance asks for blood reports. If they have been, some patient wants to go abroad, they want blood reports. And by then like a blood report, some patient needs health certificates and they need blood report. And you will see cytopenias. So cytopenia. Then you should know what is the cause of cytopenia. Cause. And you will try to find out the cause of cytopenia. That's how they are discovered. That's how they are identified. And remember that if the cytopenia is present in the old age group in asymptomatic patient, think about MDS as one of the differential diagnosis. Old age group of patients are asymptomatic, cytopenias are many. MDS is one of the highly suspicious diseases. So cytopenia, if you have anemia, which is the most common cytopenia in this case, MDS patient na sabanda earliest dekhine bhaneko anemia. So anemia, which is most common in this case. So you may have symptoms related to anemia. What are the symptoms related to anemia? What are the symptoms related to anemia?
Fatigue, pallor, shortness of
Pallor, shortness of breath, palpitation. Severe anemia, you can have swelling, edema, and palpitations, amenorrhea. These are the various manifestations of anemia. And they may present with thrombocytopenia as well. If you have thrombocytopenia, you have bleeding disorders, abnormal bleeding, like excessive menstrual bleeding, you may have purpura, you may have GI bleed, you may have subcutaneous bleeds, and there may be bleeding, but for bleeding to happen, platelet count should be very low. It's commonly or they may present with symptoms of leukopenia. Usually neutropenia happens in case of MDS. They may have recurrent infections. Recurrent infection varies. They have been treated for infection like 1 month back, you received the adequate doses of antibiotic, but still after 1 month you have another infection. So this usually happens in what? Either in immunocompromised states or leukopenia. So patient may present with any of these symptoms, or they may be asymptomatic as well. They may just present with symptoms of anemia. Sometimes they may just present with symptoms of thrombocytopenia, sometimes or leukopenia. Sometimes they may have a combined symptom. You may have pallor, fatigue, as well as purpura. You may have infections, and it depends on the patient. Remember that lymphadenopathy and hepatosplenomegaly are rare. There is rarity in the lymphadenopathy and hepatosplenomegaly. Despite of cytopenias, you don't have splenomegaly. In which case you have splenomegaly? Another. In which type of anemia you have splenomegaly? Which anemia present with hemolytic anemia? Any causes of hemolytic anemia may have splenomegaly. Do you have splenomegaly in sickle cell or not?
No, sir.
सिकल सेलमा स्प्लिनोमेगाली हुन्छ कि हुँदैन?
इनिशियली हुन्छ पछि
हुँदैन,
हुँदैन।
हुँदैन।
In young, I mean in children, they may have up to 6 years up to age, you may have splenomegaly. But in adult or old age group, you don't have splenomegaly in sickle cell. But splenomegaly can happen in thalassemia. Right? Lymphadenopathy and hepatosplenia are there. Sometimes 10 to 20% of cases you may have marginal splenomegaly. Right? But it is not that common. Right? So if there is a massive splenomegaly, hepatomegaly, then you have to change your diagnosis. Okay, let's begin to the diagnosis. How to diagnose the case? From our history, from clinical manifestations, from epidemiological character, we think this could be MDS. The diagnosis is so when you suspect MDS, usually in the old age patients present with cytopenias, unexplained cytopenias, and unexplained anemias, and old age patient either or symptoms of cytopenias, and then we suspect MDS. But diagnosis should be confirmed. And diagnosis, we need two important criteria. One is cytopenias, and there should be anemia, leukopenia, or thrombocytopenia, or at least any two, and with hypercellular or normal bone marrow. In early stage, there may be normal bone marrow as well, with dysplastic myeloid cell. Remember that. And 2-3 kinds. Cytopenia is compulsory, and bone marrow should be now normal or hypercellular. There should not be hypercellular bone marrow. And what is the condition where you have hypercellular bone marrow with cytopenia? Which disease is hypercellular bone marrow with cytopenia? Hematological disorder.
Aplastic anemia.
Aplastic anemia. Good. In aplastic anemia, what happens? You have a hypocellular bone marrow with cytopenia. This is one of the differentiating points. And there should be dysplastic cells as well. Dysplastic cells from myeloid lines. And they may have a clinical manifestation of cytopenia. And 50% patients are asymptomatic, but another 50% patient may present with anemia, symptoms of anemia, or symptoms of leukemia, or thrombocytopenia. And there may be a history of exposure to those risk factors like exposure to various chemotherapies or exposure to benzene and exposure to alkylating agents, or they may have previous myeloproliferative disorders. And so when you have all this in combination, then we can diagnose MDS. ठीक छ, बुझ्यौ यहाँसम्म? Okay. Next, investigations. How to investigate this case? I'm just talking about the MDS. We can have a general investigations, LFT, RFT, and all these investigations. But what are the diagnostic investigations? Here, important. LFT, RFT is not that important. That will not help you to diagnose MDS. But that may help you to manage management, and that may help you to prognosticate, but not in diagnosis. So the first important investigation for diagnosis is what? Peripheral blood smears. Blood and complete blood count with peripheral blood smears is the first important. In blood, what we see? Cytopenias with abnormal looking cells. And there may be cytopenias with abnormal or dysplastic cells. And total count is also reduced. Along with those cells which are present, they are also not normal, dysplastic. And there may be anemia with neutropenia from the cytopenia. And RBC, though anemia in this case is usually macrocytic type because of rapid destruction with decreased retic counts. And macrocytic RBC के मा हुन्छ अर्को megaloblastic.
Myeloblastic.
Megaloblastic. Anemia also you have a macrocytic pictures. And there is decreased reticular count. Usually what happens when there is cytopenias or decreased counts, retics are usually increased. Retics should be increased. Retics like bone marrow is functioning normally. But here it may be decreased. So in case of neutrophil, their neutrophils are usually hypogranular. Granules decrease हुन्छ and segmentation पनि either decrease हुन्छ अथवा कहिलेकाहीँ it may be increase. That means the neutrophils are not normal type. They are abnormal, dysplastic neutrophils. So they have what? Hypogranular or hyposegmented neutrophils. And the platelets are giant. The giant platelets and big platelets. So though they are having cells, those cells are not normal. They are dysplastic. Okay. So the first investigation is complete blood count with peripheral blood spin. And next important investigations for diagnosis is what? Bone marrow. And bone marrow is very important. And because from cytopenias, you can't 100% confirm that this is what? MDS. And we can guess. We can guess. We can suspect. But there are so many causes which can lead to cytopenias in peripheral blood. And we have to rule out that too. So another important clue is bone marrow examination. We can do bone marrow biopsy or bone marrow aspiration. And if in the aspiration you have adequate sample and you can see from there if the aspiration is not sufficient or conclusion, you can go for bone marrow biopsy. And so in bone marrow, usually what we should hyper or normal cellular bone marrow. Bone marrow is usually hyper or normal cellular with dysplastic changes in at least 10% of cells of the one or more. So at least 10% of the cells in the bone marrow should be dysplastic and dysplasia. At least 10%. And bone marrow is always hyper or normal cellular. Hypocellular bone marrow, then think about plastic anemia. And cytopenias with hypocellular bone marrow, you can think about plastic anemia. And there may be presence of blood cells in the bone marrow. Blood cells present on such. And remember that blood cells should be less than 20%. Maybe see 8 to 10% around. So why it is 20%? Because if the blood cells are more than 20%, that means that is acute leukemia. Blood cells 20% body weight, that is the feature of acute leukemia. So the most important diagnostic workup is what? Complete blood count with peripheral blood smear. Another is bone marrow examination, which may include aspiration or biopsy. Any questions? Any question? Okay. Okay. So bone marrow, it is the same thing what we have talked. 20% of hypocellular marrow can cause difficulty in diagnosis, but following features can help. There is most of the time it is hyper or normal cell, but in 10 to 20%, sometimes we have hypocellular in early stage. So at that time you may have confusion, the confusion with plastic. So there may be some other, differentiating point from this plastic. You have ring sideroblast, hypogranulated, hyposegmented granulocyte, increased myeloblast, megaloblast with multiple nuclei, megakaryocytes with disorganized nuclei. These are the features which will help to differentiate between aplastic and MDS in case of hypocellular bone marrow. But most of the time it is hyper, which is not hyper either. Okay, another very important point in investigation is cytogenetics. That means gene analysis. By flowmetry we can do fish cancer, which can be used. cytogenetic abnormality is another core feature of MDS because this is a what genetic mutation. 70 to 80% are disease of genetic mutation. Abnormal cytogenetics are seen in about 70% of patients. There are 7% of primary cases. And 90% of secondary MDS. Cytogenetic abnormality more common secondary and very useful when bone marrow is non-conclusive. It's useful when bone marrow is non-conclusive. Bone marrow often confusion bone. And hypercellular sign, hypo and confusion you can do. And remember that at that time it is important. And remember that it is very expensive. Cytogenetic analysis is expensive. And in our college we don't do this. And it is done in certain centers in Nepal. It's expensive, but it is very diagnostic. And usually, what are the cytogenetic abnormal we see is there is chromosomal deletion of long arm of 5, 7, 20, 11, 30, and short arm of 12 and 13. And chromosome deletion, and which is the most common cytogenetic abnormalities. And you buy urban but these are the most common. Okay. Another is loss of whole chromosome, 5 to 7. It is one of the most common cytogenetic abnormalities which is seen in MDS. There is whole chromosome is lost. 5 or 7 number of chromosome lost. And there may be trisomy of 8, 11, and 21 chromosome. There are various cytogenetic abnormalities. Right? So it is usually done in the bone marrow peripheral bone smear are confusing and non-conclusive. And in European America, what they do, they commonly do it. But in Nepal, it's very expensive and patient afford something. So we don't prefer it as the first line. Okay, now we move to differential diagnosis. And what are the differential diagnosis? First, since they have a macrocytic anemia between vitamin B12 and folate, which also causes macrocytic anemia and macrocytic anemia also. So it can be done by measuring this B12 and folate level and asking about the food habits of the patient. And if there is presence of sideroblasts, we have to differentiate between B6 deficiency and which also causes sideroblastic anemia. And in this case, what we can do, sometimes pyridoxine trial can run us also. We give pyridoxine for a certain period of time and see the improvement. If after giving pyridoxine, there is increase in the counts and increase, there is bone marrow becomes improved, bone marrow improves, after bone marrow reports become better, then we can say it's probably due to B6 deficiency. And then maybe bone marrow dysplasia in viral infections, chemical drugs interaction, various kind of drugs, various kind of viral infections, and exposure to various kind of chemical sometimes cause bone marrow dysplasia. That means they have production of abnormal cells. But this can be differentiated because it is usually a viral infection. It is a transient. It doesn't happen for years and years. It happens for days, days or weeks, and viral infection. So after that, what happens? It should be improved. And after improvement of viral infection, and blood report should be improved. But if it persists for years, months, it is less likely viral infection. Another is AML, but sometimes we have to differentiate between so it depends on the blast. If the blast cell is more than 20%, then it is AML. So this is the differential diagnosis. We have to differentiate, which are common in case of MDS. So now let's talk about the prognosis. How is the prognosis? And usually MDS is a progressive disease, which eventually lead to bone marrow failure and AML. And bone marrow failure, the patient may die because of AML, or the patient may die of bone marrow failure. And survival varies